The director of psychology and neuropsychology at Mount Washington Pediatric Hospital in Baltimore, and he's going to talk to us about sleep interventions. Then we'll go to a little after 12, and then we'll take a lunch break. All right. All right.
There's my disclosure information. David is a 10-month-old infant who falls asleep every night while being rocked by one of his parents. While they hold him, he's usually drinking a bottle. He appears to try and fight falling asleep, and his parents do not put him in his crib until he has been sound asleep for at least 10 minutes. David wakes up crying at least twice every night, and his parents follow the same routine to get him back to sleep. David's parents are exhausted and frustrated, and they're asking for help. Sound familiar? So let's see what we can do to help David and his parents. Most infants, toddlers, and children with sleep problems are normal kids who have simply learned maladaptive sleep patterns and habits. Their sleep and bedtime problems typically can be addressed easily and quickly. Whoops. Briefly, we'll talk about normal sleep patterns. Sleep occurs in repeating cycles of REM, rapid eye movement, and non-REM, sleep throughout the night. And non-REM further divides into 4 stages, from drowsiness into very deep sleep. Awakenings and arousals are normal in infants, children, adults too. We all do this. We all wake up at night. A number of times we may even sit up straight, may even look around, and then just go right back to sleep, and we don't even remember that we woke up. But these arousals and awakenings and partial awakenings are normal. The deepest sleep usually comes at the beginning of the night and again at the end of the night. And of course there are developmental changes in the need for sleep. Newborns usually require around 16 hours of sleep, and then by the time late childhood, adolescence, about 9 hours. Common sleep problems: bedtime resistance or stalling, young children who will do anything to avoid going to sleep, difficulty falling asleep, nighttime awakenings, feedings during the night, and parasomnias, or these partial awakenings, like sleep talking, sleepwalking, sleep terrors. In assessing sleep and bedtime problems, the first thing that we want to do is determine whether the sleep problems represent the learning of maladaptive sleep patterns and habits, or whether they represent more severe and pervasive emotional problems. So we just said that in most cases, these are normal kids with, who have developed these patterns. That's not always the case, though. So clearly children with anxiety, depression, autism, probably ADHD, or children who are on medication are more likely to have sleep problems. Most of the kids who come into our offices just with a sleep problem do not fall into that category. If a child's sleep patterns are, I've seen a lot of these kids and work with families, and I'm often asked if it's a problem, and my approach is if these sleep patterns are causing a problem for the child or their parents, then there's a sleep problem. So what do we do? Obviously, parent interview, including a history of the child's sleep and bedtime patterns, history of the sleep problems, history of the parent's attempts to address those problems. Child interview, if the child is old enough. A sleep diary or a sleep journal is critical to assess the current sleep status. So we really want to get, before we start an intervention, it's always helpful to get some baseline data on how much a child is actually sleeping. And often typically parents are surprised when they do that, but we like to know what time a child falls asleep, how long they're asleep, and when they wake up, and then we calculate that, and I'll often chart and graph that for a parent. It's also important as a child is making progress to be able to demonstrate that, and graphs are great to show, even when there's still some challenges, that a child's actually sleeping more. And we want to ask about caffeine intake, coffee, tea, soda, and in breastfeeding parents, we want to ask them as well in terms of their own intake. All right, sleep associations. This is probably the crux of the problem in many, if not most, cases. Children learn to connect certain conditions with falling asleep. We all learn this. So whatever the context is, the contextual cues, whatever is going on in that child's environment, that child is associating with falling asleep. So if that child is being rocked to sleep, they're associating being rocked with falling asleep. If they fall asleep drinking a bottle, they associate drinking a bottle with falling asleep. When a child wakes up during the night, as most kids do, that child will look for those same conditions as when they fell asleep. Now, there are some kids that are naturally adaptable and flexible, and even if they're rocked to sleep, they can put themselves back to sleep when they wake up in the middle of the night. However, in many, many cases, that's really hard for an infant or a young child to do. And they typically will look for those same conditions, and if those same conditions are not there, they'll have trouble falling back asleep, and they'll try to recreate those conditions. So, it's best to avoid feeding or rocking a child to sleep, from a behavioral standpoint, that is, and if you want your child to be able to learn to put themselves to sleep and to put themselves back to sleep. That statement is a little controversial, and parents will sometimes tell me, well, I like rocking my child to sleep. Is there a problem? Is it wrong? Am I hurting my child if I am rocking them to sleep? So my answer, if it's a young child, is almost always, no, there's not a problem. If that's what you want to do, that's fine. Go ahead. Typically, I'm a psychologist. I'm not a pediatrician. So typically, when a family comes to see me, they're frustrated. This has been going on for a long time, and they're looking for answers. Would like to do something differently. But generally, I'll tell a parent, if you want to rock your child to sleep, that's fine. Just realize that you may have to do that every night. So at some point, your child is going to need to learn how to calm themselves, self-soothe, put themselves to sleep. You can do this now. You can do it in 2 months. You can do it in 2 years. But sometime before they go to college, they're going to have to learn to put themselves to sleep. The child should be put down when tired but still awake. And that's the best way for a child to learn how to put themselves to sleep. So let's talk about some interventions. Most people are probably familiar with Ferber, one of the granddaddies of sleep, up in Boston. The more recent edition of his book, the 2006 book, I think is a lot better than the one that came out in the 80s. I think it's a lot more user-friendly. But this is one of the basic interventions that he talks about. And using this intervention, children will learn to fall asleep by themselves at the beginning of the night under new conditions, so they form new associations. So we start with consistent and comforting bedtime rituals, and that's pretty standard. So most parents are already doing that. If not, we encourage them to do that. A bath at a certain time, read some books, sing some songs, whatever it is, something that's comforting that the parent can relax into and a child finds enjoyable. Ideally, the child will be in a separate room from the parents. And again, we're talking about an intervention now. So have you seen parents and families in your practices where they are asking questions about co-sleeping? That when I'm asked that question also, my response generally is it's up to you. I'm sure there are advantages in co-sleeping, there are disadvantages. If a parent wants to do that, that's fine, and then we'll try to work around that with the intervention. If someone will ask me if there's any concerns about that, I will tell them that there is a small amount of data suggesting that infants might be at somewhat of a risk for suffocation if they're sleeping in the same bed as their parents. Again, most of the time when I have parents in my office, they've been going at this for a long time. They're sleep deprived, the parents, they're exhausted, they want some help. So in terms of an intervention, ideally the child will be in a separate room. Parents are warned that their child may cry, and the parent may not get a lot of sleep initially. So we want to make sure that the parent is ready for this. If it's a two-parent family, they're going to need to work in a team. So the parents really need to be psychologically ready for this. So we've spent a fair amount of time talking about this, and they need to be comfortable with their child crying for a short period of time without them in the room. Ideally, it's not done before parents are going to go away on vacation or leave town, or child's going to be sleeping in a grandparent's house. And of course, you don't want to start a sleep program if a child is sick or teething, or there's some other significant situation going on in their lives. So the parents really need to be ready. And then the parents are told that they're going to want to put their child to bed later than usual, so their child is good and tired. After the bedtime routines, the parent puts their child to bed and leaves the room. Here's a standard. There are 7,000 variations on this, but this is, I'm sure most of you are familiar, but this is the standard approach. If the child calls or cries for the parent will check on that child briefly at increasing intervals. So here's a standard one. The parent will go in after 3 minutes. They'll leave. They'll come back after 5 minutes. If their child is crying, they'll leave. They'll come back after 10 minutes. And then they'll continue to return every 10 minutes until their child falls asleep without the parent in the room. The child will fall asleep at some point without the parent being in the room, and that's the key. That's what needs to happen in order for that child to form new associations with falling asleep. Now, the parent only returns to the room if the child is crying loudly. So if the 3 minutes are up or the 5 minutes are up, and the parent hears the child, they're crying, and as the parent's getting ready, they hear the crying kind of wind down into a little whimper. I encourage parents to wait, just wait, see what happens. If the child stops crying, then you don't need to go in. Parents are also instructed very, very clearly to never spend more than 1 minute in the child's room. And I don't think I wrote this up here, but parents are also instructed not to pick their child up. So the child stays in the crib, the bed, whatever. Parent comes in, just a little pat, a little kiss on the head. You're fine. I love you. Doing a nice job. I'll see you in the morning. Good night. And then they leave. It's really for reassurance for the child and reassurance for the parent that their child is okay. Repeat the sequence if the child wakes up later that night and cries. Same sequence. Second night, repeat the same sequence, although the parent waits longer before going in the first time. This time they'll wait 5 minutes before going in, then 10 minutes, then every 12 minutes until the child is asleep. These numbers are arbitrary, and they can be anything. So this is worked out with the parent based on what the parent is comfortable doing. The third night, repeat the sequence, starting with 10 minutes, then every 15 minutes. And then you continue increasing the intervals every night until you reach about 30 minutes, and then maintain that until the child falls asleep. Parents control how fast they want to progress. Some parents that I've worked with have a lot of difficulty, and they want to increase by 1 minute at a time. And my response is, fine, sure, it will work. It will take longer, but if that's what you want to do, great. Other parents want to get it done. They say, got 1 week, we want to do this. Terrific. Parental consistency is critical. It's absolutely critical. So in the previous talk, we heard about different kinds of reinforcement. So the worst thing that can happen, the absolute worst thing that can happen, is that a parent can follow this program night 1, night 2, and then night 3, when the child's crying or the baby's crying, the parent can't stand it. They go in, they pick their baby up, and they hold their baby, and that's called intermittent reinforcement, which is reinforcement not for every incident of behavior, but intermittent reinforcement. And that's the most powerful form of reinforcement and the best way to strengthen that behavior. So that's the best way to get your child to cry even more, because then the infant, toddler is learning, if they're crying and mom's not coming in, dad's not coming in, I need to just cry harder. I need to work harder to get them to come in. So that consistency is critical, and I always discuss that with parents, and I always warn them, say, these programs work. I'll help you, I'll support you, but you got to be ready, and you have to stick to it. Because if you're not going to stick to it, it won't work, and you could even be taking a step back. So I typically warn parents that this may take a few weeks. In my experience, I've worked with many, many families over many years. Rarely does it take more than 1 to 2 weeks. So these are really quick interventions, and if parents are following the program, they're generally highly successful. Ferber's not the only sleep expert. There are many. Kim West is a social worker, actually, who has specialized in sleep for a long time, the Sleep Lady. And her book came out in 2010, and it's a little bit different, and it's a good alternative. So there are some different kinds of approaches. And she offers some things that are nice for parents who simply just can't let their child cry unattended. They just can't. So one of the things that she calls the sleep shuffle is a parent will sit right next to the child's crib or bed where they can comfort the child until they're asleep. They can put their hands on them, they can talk to them, sing to them. Every few days, the parent moves a little bit farther across the room towards the door. Same chair, they just move the chair a little bit farther away. They still comfort the child, they can talk to them, they can't pick them up, they can't touch them. But then after several days, the parent is now out in the hall, and they can, even in the hall, they can continue to comfort their child as needed while staying seated. We've used this with a number of families, and it can be very effective. And in some cases, that's it. That's all they need to do, and then it's done. Some parents find this sort of a softer, easier, more gradual approach and like it, and sometimes this does the job. If not, if the child is still having difficulty falling asleep, the child has at least acclimated to not having their parent right next to them and touching them, then we can start that progressive waiting approach, which we had just talked about, and it often works very quickly at that point. If a parent is really uncomfortable leaving their crying child alone, they can set up a video camera in the child's room for reassurance. That sometimes helps, and that sometimes makes it worse for parents to be able to see. Yeah?
Is there any data that suggests there's any difficulty with just simply letting the child cry until they go to sleep?
There's no data that I'm aware of suggesting that there's any difficulty with letting a child cry until they fall asleep. And I have worked with some families that have wanted to do that, and it works. That is perceived by many families as harsh and severe and anathema to some parents. So the point is, when you do that, it works pretty quickly. So most kids are fine and they're not scarred. Most parents that I work with don't want to do that, and they want to plan. So don't know any data that it hurts you. I think it works. The vast majority of families that I've worked with don't want to do that. They want to be able to go in and see their child, so they would rather, a more gradual approach. The nice things about these gradual approaches, they're not so gradual. I mean, if a parent can really do this, 1 to 2 weeks and they're done. Letting a child cry, can often work in 2 nights. So, no, I don't know any data that it is harmful. Limit setting for bedtime resistance. This is appropriate, especially for kids that are a little older and that can get out of bed. So for children who resist going to bed at night, children are smart and they will do whatever works. That's their job, to control their world. They'll do whatever works, they'll do it. They'll figure it out and they'll do it. So the question for parents before we start a program like this is, who is in charge? Ken talked a little bit about this in his early talk. The child needs to know that the parent is in charge. It's that simple. Parent has to be in charge. Child needs to know that. So we put the child to bed later than usual, 1 or even 2 hours later than usual. That's fine. I tell parents that they may be tired, but they're tired anyway because they're not getting a lot of sleep. You're tired. Everybody's tired. So we sometimes will push the bedtime back even as much as 2 hours, so a child's really good and tired. Sometimes that is all that it takes for a young child. As the child begins to fall asleep, because they're exhausted 2 hours after their typical bedtime, and they'll fall asleep. So if that works, then we'll gradually gradually move that bedtime up at 15-minute intervals every few nights until a more appropriate bedtime is achieved. And sometimes there's no crying, and that's all that it takes. And after a couple weeks, we got the right bedtime, child's fine, falling asleep, and it's beautiful. Doesn't always work. So when I talk with parents, it's important, and when you guys are talking with parents in your offices, it's important, well, at least my approach is not to dictate what happens, but to present options for parents and to have them really own what's going on and own the program. So parents are really coming up with this program. So parents, I really insist that parents identify which behaviors in their child they want to fix, to end, to decrease, and then the parent, I help the parent understand how they may, right now, inadvertently be reinforcing that behavior. And parents are usually really, they're okay with this. So the parent develops the plan to end the undesirable behavior in the child. And I am often in a position where I'll say, well, this is what you can do. You can do this, you can do this, you can do this, this, this. 5 things. Let's talk about them all. We'll talk about the cost and benefit for each one, and we'll make predictions, and then you tell me what feels right to you. What do you think you can do? Because you're going to have to do this. I'll be available. You can call me, but you're going to have to do this. So it's really important that a parent buys into this. If a parent has, and most parents are great with this, some parents have difficulty, again, as Ken discussed in his early talk, some parents have difficulty setting limits all the time, not just at night, but throughout the day. We know, you see the parents, you know them, you know who they are. In those cases, I would not recommend a sleep program until some parent training, behavior management first. The parent really needs to have some success in setting limits with their child, and if they don't, a nighttime program is not going to work. It just will not work. So sometimes either doing that in your office or referring them to behavior management specialist will help. These programs are pretty quick, and so I've had lots of families where I say, well, this will work in 2 months. We need to do this first. We need to do some real behavioral compliance training in the daytime so the child understands you're the parent and you feel that you're competent in setting these limits. Preschool, school-age children often respond to an incentive program and sticker chart. And with some kids, as Alice talked about in her talk, some kids, that's all they need. A little chart, stickers. They get stickers for complying. They cash the stickers in for prizes. And sometimes that's enough. Children can be given a sleep pass that allows them one opportunity per night to come to the parent or to request a drink. And once that pass is used, the child remains in their room and they can't come out, or a consequence follows. Whatever that consequence is, that's part of that program. The sleep pass is nice because it gives kids a sense of control. So they don't always feel like everything's being imposed on them. They have this sleep pass, and they get to decide when they want to use it. So it's kind of a nice touch, and that can be helpful for kids.
What age would this be?
Sleep pass? I've used it typically with, like 5 and 6 year olds and up. But it's your judgment. I mean, if you know your families and kids, and you can talk with your parents. So I will often, I think you're getting a sort of a flavor. I've done this a long time, and I've done it a lot, so I know what to do, but I I really, really resist telling parents what to do. So, if it's sort of borderline, I will present this to a parent, and I'll say, well, you think this will work with your kid? This sleep pass, does it make sense? Does it not make sense? And how do you think your child will respond? So I often use that to help me make that judgment. If the child will stay in bed, then the parent can use the progressive weighting approach as we discussed. If a child is older and will not stay in bed, then a barrier needs to be created. A parent can close the child's door and tell the child that the door will open if the child is quiet and stays in their room. Parent may need to hold the door closed. The child learns to remain quiet and in the room so the door can stay open. I've actually done this with many families, and it is highly effective. I would not do this with a child with a major anxiety disorder. I would not do this with a child who's having real nightmares, because it can be scary to a child. But if the child does not have those issues, this is a highly effective and quick way to get a child to comply. Because kids, they want that door open, and they'll stop crying and stay in the room for that door to stay open. And of course, a parent needs to be able to do that, to keep that door closed. But usually it's a really brief period of time. It can be 30 seconds. If a parent is not able to do that, then they can put a chain lock on the door, put up a baby gate, put up one baby gate on top of another baby gate if a child can climb over. Parents have told me, well, I did that, and my child, or what if my child just, they're at the gate, they want to come out, they lie down and fall asleep right on the floor. So I say, great, fine. They fell asleep and they slept. Okay, they'll get tired, and it won't take more than a couple days before they go back into their bed and sleep in their bed. And most children really learn pretty quickly. Setting up boundaries and gates, doors, whatever, should be paired with a positive incentive program. It is really important to add a positive component to this, not just confine a child. So to the extent that a child is cooperating, complying, we definitely want some praise and rewards to be paired with that. Now, if a parent is, some parents are simply unable or uncomfortable with setting up boundaries, and I understand that. So parents one thing we do sometimes, parents will let their child sleep on their floor in a sleeping bag for a few days. That can work. I've done that with a few parents where it hasn't really helped a lot, but sometimes it's a nice transition, and parents like that. And I have had some kids, where that does seem to have helped. If not, we can go to the sleep shuffle, and a parent can, either with an infant or even a child who's in a bed, they can do that sleep shuffle and do the gradual moving the chair out. And that often works. So there are ways that parents can try to avoid setting up that boundary. It takes longer. And some parents, great, that's fine. I'll take 3 months. I don't want to close that door. I don't want to put up a baby gate. So terrific. It'll take 3 months. We'll do it. A lot of parents, again, by the time I see them, they're exhausted. And they've been doing this for a long time, and they want it to change. All right, interventions for nighttime feedings. Nighttime feedings can cause disruption at night. So first thing that we want to know is if a child is getting much nutrition from nursing or drinking the bottle. If a child is feeding primarily for comfort and not getting substantial nutrition, then we just do the progressive weighting approach. If a child is getting substantial nutrition from their nighttime feedings, then first we have to wean the child from nutrition during the night before we start a program. So we can do that letting the child nurse for shorter and shorter periods over several days, or if a child's drinking a bottle at night, we can dilute the milk with water. And we do that over several days. So 90% milk, 10% water. A couple days later, 80-20, 70-30. Again, it can go a little bit faster. But this really, I've done this many times, and this works. And you want to get to the point where a child is just drinking water, and then you can stop the bottle abruptly, or you can phase it out by having less and less water be in the bottle. Most kids, by the time it's only water in their bottle, throw it down. They don't want it. So you can do that in a week or a week and a half. So when the parent is confident that the child is no longer waking up because of hunger, then they can start the progressive weighting approach. Parents can be told in early infancy to try and avoid having an infant fall asleep while breastfeeding or bottle feeding. And it's best to put your baby down while tired but awake. This helps them learn to self-soothe and fall asleep on their own. Again, most of the time when I do clinical work, there is a problem. That's why they come to my office. Sometimes I do talks or parents ask me, when their child is still a baby, what do I recommend? And again, I say, you can do whatever you want, No, it will not hurt your child if they fall asleep drinking a bottle, but it's in their best interest to learn to self-soothe and to fall asleep on their own. So it's really parental choice. Nightmares, real quickly, we all know what nightmares are. They're a little different, so we don't typically use these behavioral sleep programs for nightmares. We want to help a child feel, we want to give a child reassurance. They can have a night light, obvious things we try to avoid, frightening TV shows, movies, video games. Try to encourage a child to talk about the nightmare, maybe the next day. They can draw pictures, and often that's enough. We can help a child think about a strong person or a magical weapon that can help them feel protected. And certainly we want to explore stresses that may be contributing to nightmares, which would be obvious. And that's something that you do every day in your offices, and you would, if the anxiety is overwhelming, perhaps a referral to a mental health professional. But a lot of the anxiety can be alleviated just by helping a child talk about it. But again, nightmares, don't use this program. We try to help a child feel more comfortable first. Partial awakenings, these are arousals. They happen typically during non-REM sleep, and they often take place. So non-REM sleep is when we do not dream. We dream during REM sleep, so these are not dreams. And they often take place at the end of the first or second sleep cycle between 1 and 4 hours after falling asleep, precisely when the parents are usually going to bed. So often parents are going to bed or maybe have just fallen asleep, and then they hear their child walking through the house or some blood-curdling scream, which is a night terror. So sleep talking, sleep walking, sleep terrors, we sometimes call them confusional arousals. And again, they're not dreams. Sure, you've seen these in your practices, or maybe you've had kids. We all know about sleepwalking, sleep talking. Night terrors or sleep terrors can be frightening. I mean, really, really frightening. Kids, blood-curdling screams, and they don't make eye contact. It looks like they're looking through you. They can be very, very frightening. So generally, they do not signify severe emotional disturbance, especially if we see them in younger kids, not abnormal at all. And the general approach is safety precautions. We want to make sure they're safe. These episodes are generally brief. Parents are not encouraged to try to wake up or arouse their child. That can create more anxiety in their kids. Generally, we want to keep them safe, guide them back to bed, not a lot of talking about it. And then they typically will go away. There are lots and lots of books about sleep, and I've read many of them, looked at many of them. These are two that I recommend. A little different approaches. Nice representation, I think, of what's out there, and these are good ones. And I think in the handout there's also some sleep hygiene tips. Any questions? Yes?
Just, you didn't really get into preparing the child for going to bed, sleeping at the different ages. And a lot of it is sort of standard, soft music, no roughhousing, blah, 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 blah. But I think parents very often need to have that really impressed on them, that they're keeping the child awake.
I agree 100%. I've had I work with many families where they work in different shifts, or dad comes home, it's a baby, dad comes home at 7 o'clock or 8 o'clock. They want to keep the baby up till dad's home. And what does dad do? Roughhousing, playing around, stirring little Johnny up. So it's a really good point. It's really critical that parents understand. We're talking about downtime, slowing things down, and some real nice comforting rituals.
A lot
Yes.
of parents are falling asleep to TVs and so on, and they're having their children fall asleep to TVs, which is amazing.
So when parents, are you a pediatrician?
No,
Oh,
a
okay.
counselor.
Absolutely true. Very common in America today, and it's a problem. It's a problem. Yes?
So I work with an inner city population, and I had worked in suburban practice prior to that. And the challenge that I see in my inner city population, sometimes in dealing with my adolescent parents and sometimes dealing with my non-adolescent parents, is that they are sleeping in the same room with their children. I have some shelter patients. I have one family in particular, she and her 4 children are in one room together. And so it creates this cycle where you can't really advocate for
It is a huge, I don't have an answer. It is a huge problem. The hospital I work at is in Baltimore, and we see a lot of Baltimore families that live with a lot of family members in a small place. And very common. And I encourage, if possible, I encourage, if the parent is okay, for the child not to sleep literally in the same bed, but at least, in another bed or cot or something in the room. There still are, and we can talk some more during lunch. There still are some behavioral strategies, even with co-sleeping families, even with families that want to do that. There are some behavioral strategies that we can use. I mean, some co-sleeping families are okay with everyone sleeping in the bed, but little Johnny makes mom lie down with him at 7 o'clock and lie there until he falls asleep. That doesn't have to happen. So if you want to all sleep in the same bed, great. You don't all have to go to sleep at the same time. So there are some behavioral strategies that we can, and modifications of some of these programs that we can use. But that's a real problem. It's a real issue.
I just wanted to make a comment, because I don't know if there are any other pediatricians here that have had this issue, but the sleep care problem, for me, is one of the more difficult ones. And your statement says that they're usually brief. Well, I've had parents come in and say these last 30 to 45 minutes. And one of the things that I have tried to do, although I have no studies to support this, is encourage them to make sure that the child has a protein-rich snack before they go to bed rather than cookies or something high in sugar. Because I honestly believe that at times what they're dealing with is hypoglycemia in the middle of the night. And if we try to stabilize the amount of insulin that's secreted, that we're not less likely to have it. And even though there's nothing in the literature that talks about that, I found it to be pretty effective.
That's very interesting. I have not heard that, but that certainly is interesting. My experience is that, and one of my kids are 17 and 20, but one of my daughters had sleep terrors when she was younger, and I've worked with many families and seen some on videotape that have been like horrifying. My experience is that most are shorter in duration than that. But I mean, my approach is if there's something they can try, if it's not going to hurt, go for it. I mean, certainly.
I'm just wondering, how does people have that experience if they're longer than the brief episode?
There also are some medications that have been tried for older kids when it really continues and really becomes problematic. But
I'm talking more about the younger.
yeah, right.